one question that kind of rose to my mind when you mentioned BCG refractory. Do you see patients that have progressed to muscle invasive disease from high risk non-muscle invasive disease any different than those presenting with de novo muscle invasive disease?
Uh, yeah, I always thought that they have worse prognosis, and there's some opposing, I think, literature on this. I think the most recent one from MD Anderson or from MSK, I believe, said that if you get neoadjuvant chemotherapy, you're pretty much the same as the other ones. But the numbers get pretty small. I think most of the data suggest that if you progress through to muscle invasive disease, that you probably have a worse prognosis, which comes into the discussion of high grade T1 because you have this decision of early cystectomy versus doing conservative therapy with BCG. But, the logical thought process is, well, why don't we try BCG first? If it doesn't work, then I'll go to cystectomy. The problem with that thought process is that you could be fine at 3 months, 6 months, 9 months, and then, a year and a half, suddenly right under your nose, you went from having nothing to suddenly T3 disease. Now you're getting neoadjuvant chemo. Now you have YPT2 disease and maybe a positive lymph node, and you're certainly at a disadvantage. So, yeah, I think the patients who progress, that's why you have to do worse. And that's why you have to pay meticulous attention to those indicators of progression. If you have multifocal disease, if you have, T1 with CIS, that's why we use blue light to be able to really map out the bladder and the pathology as well as we can.
Yeah, I mean, it's just something that I've conjectured about, but I guess we could also imagine that just like a low grade tumor can seed, and that's why we give gemcitabine, myosin, et cetera. That multiple scrapings, you can have tumors now sitting directly in the muscle layers as your patient that you previously described, the epithelium, heals over it and you've got something growing out the back. And I always tell the residents, whether it's upper tract cancer or whether it's, high risk non-muscle invasive cancer, you can't skip out on your axial imaging. You could have something growing right out through the back and feeling quite fine that everything looks good endoscopically. Yeah, I agree. I think that, there's some pretty interesting data, maybe some, molecular correlates suggesting more or less of a incidence of DNA damage response and progressors versus de novo, but it's probably a little premature to start, making any decisions on. And it's a rare enough clinical entity that I think, a trial would be a little challenging at this stage. So I agree on the lymph node dissection. Presacral nerves, are those always a part of the nodal dissection for you?
Always has, yeah. And in our data set, 5% of patients who have lymph node positive disease have them in the presacral nodal packet.
And what about ureteral margins? Do you send frozen sections?
I do still, despite the evidence against it. I think ultimately I agree that it doesn't make much of a difference, but it's such an easy thing to do. I'd hate to. It does increase the risk of upper tract recurrence, even though it's pretty rare. I do have to. I do like to get negative margins, at least, but I don't make a big deal of it if I do two or three and it's positive or atypical. At some point, I go as high as I can and set that for permanent section. Because I'm not going to do an ileal ureter on something that's atypical. Not all of those turn into something. Same thing with urethra, by the way. Over the years, again, I've sort of thought less and less of a positive, quote, positive urethral margin to an orthotopic neobladder. Now, I'm not talking about invasive. That is an absolute contraindication. I'm talking about the atypical sort of frozen section, possible CIS type of picture. That will not divert me from doing an orthotopic diversion on that patient. The urethral recurrence rates, even in that setting, are fairly low. It's less than 10%. So, I'll have a conversation with patients, see how badly they want a neobladder. Most of them, once they've made the decision, want it. So we have done intraurethral BCG for those who have recurred. And I can tell you that in my experience, I've not had to do a urethrectomy for a urethral recurrence in that setting. Most of them have been just de novo, happened to have a urethral recurrence. They had prostatic stromal involvement and later developed a urethral recurrence.